Welcome to the deep dive. Okay, so for a moment, we are stepping slightly sideways from directly studying microbes.
Yeah, we're diving into the toolkit, really, the tools we use against them.
Exactly. We're looking at pharmacology. That word itself, it comes from Greek pharmakon, meaning drug, and logia, the study of.
It's the whole science, isn't it? How chemical agents change things in living systems.
And if you're heading into healthcare, I mean, this isn't just nice to know.
Oh, absolutely not.
Yeah.
It's fundamental. You have to grasp this. Historically, it all started with what they called materia medica.
Ancient remedies, right?
Yeah, basically catalogs of natural stuff that worked. Think poppies for opium, cinchona bark that gave us quinine for malaria, and even willow bark.
Which led to salicylic acid, aspirin's precursor.
Exactly. But today, pharmacology is more structured. It's about, well, three main things, I'd say. First, what the drug actually does to the body.
The mechanism.
Right. Second, what the body does back to the drug, how it handles it. And third, crucially, all the safety systems we have in place. Rigorous systems.
Okay, that sounds like a huge puzzle. Our sources definitely frame it as this integrator, pulling together chemistry, anatomy, physiology, biochemistry.
It sits right at that intersection.
So our mission today, let's try and simplify this. We'll break down the key branches, map out how a drug moves through your system, that ADME thing, and look at the regulations keeping things safe.
Sounds like a plan. So, to get organized, pharmacology is often split into 5 main branches. Think of them as different jobs.
Go.
First, there's pharmacodynamics. This is about the drug's effect, what it does to your body, like a key fitting into a lock, triggering a response.
What happens at the cellular level?
Precisely. Second, pharmacokinetics. This is the flip side, what the body does to the drug.
Yeah.
It's the journey, absorption, distribution, metabolism, elimination. ADME.
ADME, got it.
Third, pharmacotherapeutics. This is the practical side. Choosing the right drug, the right dose, for the right reason, preventing, treating, or diagnosing disease.
Makes sense.
Fourth, toxicology. This is the study of poisons, their harmful effects. And here's a key point. All drugs are potential poisons.
Really, all of them.
Yep. It's just that therapeutic drugs are given in doses carefully calculated to be below the toxic level. It's all about the dose.
Okay, that's a critical distinction.
And finally, number 5 is pharmacy. This is the hands-on part. Preparing, mixing, dispensing drugs safely, keeping records, all that essential groundwork.
That framework helps a lot. So, starting with safety, the first step seems to be just naming these things correctly. Drugs fall into 2 big groups, right? Non-prescription.
Or OTC, over-the-counter. That includes herbal supplements too, which, importantly, often aren't FDA approved in the same way.
And the other group is prescription drugs. Need a licensed practitioner for those.
Exactly. And for safety and clear communication, every single drug actually gets 3 different names. It's like having multiple IDs.
Okay, what are they?
Well, first you have the chemical name. It's usually long, super precise, describes the structure, like 3-CMI-5-dihydroxyphenylalanine. Chemists use it mostly.
Not something you'd ask for at the counter.
Definitely not.
Yeah.
Then there's the generic name, or non-proprietary name. This is the official shorter name, like amoxicillin. Often gives you a clue about what class of drug it is. One drug, one generic name.
Simpler.
Much. And finally, the proprietary name or trade name or brand name, that's the name the company gives it, and legally licenses, like Amox for amoxicillin.
Amoxil, Tylenol, Advil, those are the brand names we usually hear.
Right. And knowing these distinctions matters, especially when you need reliable info. If you're looking up FDA-approved prescription drug details.
Where do you go?
The gold standard is the Physician's Desk Reference, the PDR. It's updated every year. It lists exactly what the FDA signed off on for that drug, whether you look it up by generic or brand name.
Okay, PDR, good to know. Now let's follow the drug itself, from the label into the body. You mentioned pharmacokinetics, the ADME process. It starts with administration.
Right, how the drug gets in. 2 main routes. Enterally, which means using the digestive system, think pills, liquids you swallow, or parenterally, which is basically any other way besides the digestive system.
Like injection.
Injections are a big one, yeah. But it also includes things like patches on the skin, inhalers.
And the route chosen makes a difference in how fast it works, doesn't it? You can put cream on locally, but for systemic effects?
Speed is often key. Intravenously, directly into a vein is the absolute fastest. Boom, it's in the bloodstream immediately. No barriers.
Instant effect.
Pretty much. Inhalation is also incredibly fast. Your lungs have this massive surface area, something like 200 square meters, perfect for absorbing things quickly into the blood.
Wow, 200 square meters, that's huge.
It really is. And another fast one is sublingually under the tongue. lots of blood vessels there, and it bypasses the liver initially. That avoids something called the first pass effect, which we'll get to.
Okay, so administration is step one. Once it's in, we have A for absorption.
Exactly. Absorption is about how quickly and how much of the drug leaves the spot where you administered it and gets into the bloodstream or target area. This ties into bioavailability.
Bioavailability. That sounds important.
It is. It's the fraction, the percentage of the administered drug that actually reaches the systemic circulation or its site of action unchanged. You take a 100-milligram pill, but maybe only 70 milligrams gets absorbed effectively. That's 70% bioavailability.
What affects that? Why wouldn't it all get absorbed?
Several things. One is surface area. Small intestine has a huge surface area, so it's great for absorption. Stomach, not so much.
Okay.
2, the rate of dissolution. How fast does the pill break down and dissolve? Can't be absorbed if it's still a solid chunk.
Makes sense.
3, lipid solubility. This is a big one. Cell membranes are fatty. Drugs that dissolve well in lipids or fats can cross those membranes much more easily. They have a VIP pass, basically.
So fat-loving drugs get in easier.
Generally, yes. And 4th, blood flow to the absorption site. More blood flow means the drug is carried away faster, maintaining a concentration gradient that encourages more absorption. High flow equals higher absorption, usually.
Got it. So administered, absorbed. Next is D for distribution.
Right. Distribution. Now, the drug is in the bloodstream. It needs to travel out of the blood and into the different body tissues and fluids to reach its target, crossing more biological membranes.
Are there places it's hard to get into? Barriers?
Oh, definitely. 2 major ones. The first is the famous blood-brain barrier. It's like super tight security for the brain, protecting it. Very selective. Only very lipid-soluble drugs or those with specific transporters can get through easily.
Keeps harmful stuff out, but also therapeutic drugs sometimes.
Exactly. It's a challenge for treating brain conditions. The second key barrier is the placental circulation during pregnancy. While it protects the fetus to some extent, it's unfortunately quite permeable to many substances.
Things like alcohol.
Alcohol, nicotine, marijuana, many prescription and non-prescription drugs. They can cross from the mother's circulation to the fetus, which is why drug use during pregnancy needs such careful consideration.
That's sobering. Okay, so after distribution, we hit M, metabolism.
Biotransformation or metabolism. Yep. This is where the body starts to chemically change the drug, primarily in the liver, although other organs chip in lungs, kidneys, even adrenal glands.
What's the goal here, just breaking it down?
The main goal is to take drugs that needed to be lipid-soluble to get absorbed and distributed, remember, and convert them into more water-soluble forms.
Why water-soluble?
Because water-soluble things are much easier for the kidneys to filter out and excrete in urine. The body's trying to clean house.
Ah, preparing it for removal.
Exactly. This often happens in 2 phases. Phase I reactions usually modify the drug chemically, maybe add an oxygen atom, make it more reactive, more ionized. Phase 2 reactions are often conjugation, sticking a larger water-soluble molecule onto the drug, like tagging it for disposal.
Okay, that makes sense. But I saw something about prodrugs here. That sounds backward. You give an inactive drug?
It does sound counterintuitive, doesn't it? But it's actually a clever strategy. A prodrug is administered in an inactive or less active form.
Why would you do that? Doesn't that make dosing tricky depending on how well someone metabolizes it?
It can add variability, yes, but it's often done for specific reasons, like take L-DOPA for Parkinson's disease. Dopamine itself can't cross the blood-brain barrier well, but L-DOPA can.
Ah, so L-DOPA is the transport form.
Precisely. It's designed to be lipid-soluble enough to get past the brain's security. Once it's inside the brain, enzymes there metabolize it into the active drug, dopamine, right where it's needed.
Okay, that is clever, like sending a package that only gets unwrapped at the destination.
That's a great analogy. So after M for metabolism, we finally get to E, elimination.
Clearance or elimination, getting rid of it.
This is the final step. The primary route out is via the kidneys, producing urine. The kidneys are amazing filters. They use 3 processes: glomerular filtration, tubular reabsorption, pulling some things back, and tubular secretion, actively pumping waste out. They handle those water-soluble metabolites we just talked about.
So mostly urine. Any other ways?
Oh, yes. Drugs can also be eliminated in bile, which then goes into the feces. Some volatile drugs or gases, like anesthetics, are breathed out by the lungs. And importantly for nursing mothers, drugs can be excreted into breast milk.
Right, another factor to consider. Okay, so that's the whole ABME journey. Administration, absorption, distribution, metabolism, elimination. Phew.
That's the life cycle of a drug in the body. in a nutshell.
Now let's shift to the effects, the responses drugs cause. We've got dose effects, time effects, variability, toxicity, first dose. Seems simple, but there's a distinction.
Crucial distinction. Dose is the amount you give at one single time. Like, take 500 milligrams now. Dosage is the total amount over a period, or the dosing regimen. Like, take 500 milligrams 3 times a day for 7 days. They are not interchangeable terms.
Got it. Single time versus total plan.
And dose leads directly to a really critical safety concept. The therapeutic index. You might hear it called the margin of safety.
Okay, therapeutic index, what is it measuring?
It's a ratio. It compares the dose of a drug that causes a lethal effect in 50% of test animals, that's the LD Euro lethal dose 50,
Okay.
to the dose that produces the desired therapeutic effect in 50% of test animals, the ED effective dose 50. So it's LD divided by ED.
LDO over EDO, so what does a high or low number mean?
A high therapeutic index means the lethal dose is much, much higher than the effective dose. There's a wide margin between getting the benefit and getting toxicity. That's generally a safer drug.
Lots of wiggle room.
Exactly. But a low therapeutic index, that means the dose needed to get the therapeutic effect is relatively close to the dose that could be lethal. The curves overlap. Those drugs are inherently riskier, require much more careful monitoring. The effective dose might be dangerously close to a toxic one.
Okay, that makes a lot of sense. Safety margin. What about time effects?
Right? Drugs don't just work instantly and forever. If you imagine a graph plotting the drug effect over time, you give the drug at time 0, there's usually a lag, a latency period, before the concentration reaches the minimum effective level. That's the onset of response.
When you start to feel it working.
Yep. Then the effect climbs to a peak effect, where the receptors are maximally engaged, concentration is highest at the target. After that, as the body metabolizes and eliminates the drug, the effect declines. The duration of action is how long the drug level stays above that minimum effective threshold.
And what determines how long that duration is?
A key factor is the drug's biological half-life. That's the time it takes for the concentration of the drug in the blood plasma to decrease by half. A short half-life usually means a shorter duration of action. Might need more frequent dosing.
Half-life. Okay. Now, a big one. Variability. You hinted at this. People don't all react the same.
Not at all. There's huge patient variability in drug response, even with the same dose. Several factors are at play. Age is a big one, newborns, and the elderly often metabolize drugs much differently than adults.
Slower, usually.
Often slower, yeah, leading to higher drug levels or longer effects. Gender can play a role. The source mentions young males might be more sensitive to barbiturates, for example. Genetics is massive. Some people inherit enzyme variations that make them unable to metabolize certain drugs effectively, like acetylcholine, a muscle relaxant.
Wow, so your genes can dictate drug reactions.
Absolutely. Then there are underlying diseases. Liver or kidney disease can severely impair metabolism and elimination. That whole ADME cleanup crew is compromised.
So the drug hangs around longer, potentially becoming toxic?
Exactly. And finally, remember that first pass effect we mentioned. If you take a drug orally, it goes from the gut straight to the liver via the portal vein before it gets into the general circulation. The liver might metabolize a significant chunk of it right away.
Reducing the amount that actually reaches the rest of the body.
Right, so the effective dose is lower than what you swallowed. This varies between people too. All these factors mean dosing often needs to be individualized.
That variability flows right into the next topic, toxicity.
It does. A toxic effect is defined as one that's harmful to a biological system. It's slightly different from an adverse effect, which might be undesirable or harmful in some situations, but not inherently toxic to the system itself.
Okay. And toxicity isn't just one thing you said. It's classified by time.
Yeah, that's a useful way to think about it. Acute toxicity happens quickly minutes or hours after exposure. Think carbon monoxide poisoning.
Immediate danger.
Right. Subacute toxicity results from repeated exposure over several days. And chronic toxicity develops over months or even years. The key here is that the rate of exposure is faster than the body's ability to eliminate the substance. It builds up gradually.
Like lead poisoning accumulating over time.
That's a classic example. It sneaks up on you because the damage happens slowly as the toxin accumulates.
So if poisoning is suspected, what's the approach?
Treatment falls into two broad categories. First is non-specific treatment. This is supportive care, manage the ABCs, airway, breathing, circulation, support vital functions. Try to remove any unabsorbed poison, maybe induce vomiting or use activated charcoal if appropriate, and crucially, identify the poison if possible.
Stabilize first, figure out what it is.
Exactly. Then, if you know the specific poison, you might be able to use specific treatment. This involves giving an antidote.
Like a direct counteragent.
Precisely. For example, nitrites can be used for cyanide poisoning, or specific antitoxins for things like botulinum toxin. Another type of specific treatment uses chelators, especially for heavy metal poisoning.
Chelators, what do they do?
A chelator is a chemical that binds tightly to the metal ion, like dimercaprol for mercury, or something called candiuro for lead. It grabs the metal, forms a complex, and that complex is then water-soluble and can be excreted by the kidneys.
So it literally pulls the metal out.
Basically, yeah. Helps the body get rid of it.
This whole discussion of safety and toxicity really underscores why we have drug laws.
Absolutely. The history of drug regulation in the U.S. shows an evolution driven by, sadly, safety crises.
Yeah.
It started relatively simply with the Pure Food and Drug Act of 1906. That mainly focused on labeling, purity, and strength for drugs already out there. Didn't require pre-approval.
Just ensuring what was in the bottle matched the label.
More or less. But the big change came after a tragedy involving a toxic solvent, diethylene glycol, being used in a medicine, killing over 100 people. That spurred the Federal Food, Drug, and Cosmetic Act of 1938. This was a landmark. For the first time, it required manufacturers to submit data proving a new drug was safe before it could be marketed. The New Drug Application, or NDA, was born. Safety first.
Okay, so 1938 is proof of safety, but not necessarily that it worked.
Correct. That piece came later, prompted by the thalidomide tragedy in Europe, though it had effects here too. The Kefauver-Harris Amendment of 1962 was passed. It required manufacturers to prove not only safety but also efficacy, that the drug actually works for its intended purpose. And this was retroactive for drugs approved since 1938.
Safety and efficacy, that's the standard now.
That's the standard. And then, to deal with drugs that had potential for abuse, the Controlled Substances Act of 1970 was enacted. It created the 5 schedules. Schedule I through V based on abuse potential and accepted medical use. Schedule I drugs, like heroin or LSD, are deemed high abuse potential with no accepted medical use. The DEA enforces this.
Schedule I, high risk, no use. Schedule V, low risk.
Generally, yes. This whole legal framework shapes the modern drug development process, which is incredibly lengthy and expensive. You need an investigational new drug application, an IND, just to start testing in humans.
And those are the clinical trial phases.
Right. Phase I trials are usually small, testing safety and dosage in healthy volunteers. Phase 2 starts testing efficacy and side effects in a small group of patients with the condition. Phase 3 expands that to a much larger group of patients, comparing it to existing treatments or placebo. This is the big hurdle for approval.
And phase 4?
Phase 4 is post-marketing surveillance. After the drug is approved and on the market, monitoring continues to track long-term safety, effectiveness in diverse populations, and rare side effects. We should also quickly mention orphan drugs.
What are those?
These are drugs developed to treat rare diseases defined in the U.S. as affecting fewer than 200,000 people. Because the market is small, there are special financial incentives provided by law to encourage companies to develop these needed therapies.
Making it viable to help smaller patient groups.
Exactly.
Okay, so as we wrap up this deep dive, it's clear that understanding all of this, the names, the branches, especially that ADME journey and the safety metrics, it's absolutely foundational if you're involved in healthcare.
Couldn't agree more. The ADME process dictates whether a drug even has a chance to work. The therapeutic index tells you how carefully you need to tread. Moving beyond ancient remedies to modern medicine required this systematic scientific approach. It allows for precision.
And looking ahead, the challenge doesn't stop, does it? The source material ends on a pretty potent note about the future.
It does. The constant battle with microorganisms developing resistance to our antimicrobial drugs. It means pharmacology can never be static. We're in a continuous race.
Which highlights why we need integrated monitoring systems like ARMS, the National Antimicrobial Resistance Monitoring System involving the FDA, CDC, USDA. They're trying to track resistance patterns.
It shows you how vital it is to keep learning, keep monitoring, keep developing new strategies just to stay effective against evolving threats. That ongoing challenge, that race, is something you as future healthcare professionals will absolutely be part of.
A crucial ongoing effort. Thank you for joining us for this deep dive into the fundamentals of pharmacology. We hope we've sparked your curiosity to keep learning more.